Welcome back to the channel. Today's topic is ST elevation acute coronary syndrome. Acute myocardial infarction with ST segment elevation on ECG is due to complete coronary artery occlusion. In the figure we see the coronary artery is totally occluded by the thrombus present overlying the atheromatous plaque. 12 lead ECG is the pivotal diagnostic tool for management. 50% of myocardial infarction related death occur before the patient reaches the hospital, and in hospital mortality is 5%. Plaque rupture and erosion followed by platelet aggregation and thrombus formation causing total coronary artery occlusion. See here the total coronary artery lumen is occluded by the thrombus, causing necrosis of the myocardial with full thickness infarction is termed as transmural infarction. This is the pathology for ST elevation myocardial infarction or acute coronary syndrome. Clinical presentation, the classic symptom, severe crushing chest pain, often retrosternal, radiating to arm, jaw, back. In 50% of cases, pain is often following physical exertion or illness. There may be associated sweating, nausea, dyspnea. Silent myocardial infarction may also be present in elderly or diabetics, patient present with breathlessness, fatigue, sudden loss of consciousness, fall in arterial pressure. In physical examination, we may get S3, S4 gallop, signs of LV dysfunction. New murmur may be present if there is mitral regurgitation or VSD as a complication. Diagnosis, first is the ECG, so it will show the ST segment elevation 1 millimeter or more in 2 or more contiguous leads. Repeat ECG if the initial ECG is non-diagnostic but suspicion remains. This is most important point. Q wave may develop later depending upon the volume of necrosis. You see the ECG here is ST segment elevation. Number 2, cardiac biomarker like TROP T or I appear after 3 to 4 hours, last for 7 to 10 days. CPK-MB also appear. Cardiac biomarkers are supportive for the diagnosis, but it should not delay the reperfusion therapy. Echocardiography and Doppler, which will show the wall motion abnormality, but the pitfall is if there is previous wall scar or ischemic ventricular wall, it will mimic the picture or acute infarction. LV ejection fraction will also be shown by the echocardiography and also the complication like MR, VSD or tamponade if anything arises as complication. Coronary angiography is the gold standard for diagnosis and PCI planning. Management strategy, initial management, morphine, oxygen if patient is hypoxemic like less than 90% saturation, nitrate, aspirin and beta blocker. MONAB. Reperfusion therapy, primary PCI is preferred if available within 120 minutes of hospital arrival. Fibrinolysis is done within 30 minutes of hospital arrival if PCI is not available. Tissue plasminogen activator TPA, tenecteplase, riteplase and streptokinase used. Adjunct therapy, antiplatelet like aspirin and P2Y12 inhibitor like clopidogrel, ticagrelor, anticoagulant like unfractionated heparin, enoxaparin, fondaparinux, statin, AC inhibitor and beta blocker. Complication, mechanical complication, electrical complication and others. Under mechanical complication, there may be ventricular septal rupture, free wall rupture, papillary muscle rupture cause acute MR. Electrical complication may be sinus tachycardia, bradycardia or arrhythmia like VT, VF and AV block. Other LV failure, cardiogenic shock, pericarditis. Key message: recognize STEMI early, confirm with ECG only, start reperfusion immediately. Early reperfusion reduces mortality dramatically. Here we see coronary artery with stenting after balloon angioplasty. Secondary prevention: the statin, antiplatelet, AC inhibitor, beta blocker, and lifestyle modification. Time is very important to protect the patient. The time is muscle. Thank you for watching this video.